The neoadjuvant approach to resectable colon cancer sort of varies depending on its institution. However, I would say that the standard treatment of resectable colon cancer is still surgical resection. However, if you look at the NCCN guideline, it says to consider giving neoadjuvant therapy in patients who are T4B or who have bulky disease. Now, if you have MMR proficient tumor, the recommendation to give a chemo, Kpox or FOLFOX setting. However, in patients who are MMR deficient, the recommendation is actually to try immunotherapy instead of chemotherapy in those patients with T4B resectable MMR deficient tumors. So the biggest unmet needs, I think there are many unmet needs that we need to figure out. For example, clearly patients who are MMR proficient, we're trying to figure out which patients really need neoadjuvant therapy. I think based on the current technology we have, the staging is very inaccurate. The data will tell you that anywhere from 15 to 25% we are overstaging the patients by our current criteria. So I think we need to do a better job of staging them. So that's a really an unmet area. The second thing that is unclear is that if you do give neoadjuvant therapy, how many cycles do you give neoadjuvantly and what do you do afterwards? Okay, and I think those are the sort of the unmet areas at least in MMR proficient tumors. In MMR deficient colorectal cancer tumor, I mean, clearly the immunotherapy do work. The data shows that the pass CR rate is high, but it is not 100% like in rectal cancer, for example. And also the similar story is that if you do give immunotherapy, how many cycles do you give before and how many cycles do you give afterwards? Other more provocative question is, can you do a possible organ preservation? Just like rectal cancer, can you give immunotherapy and not do surgery? I think those are still the unmet areas.